My name is Richard Leesungbok. I am a professor at the Department of Biomaterials and Prosthodontics in Kyung University School of Dentistry in Seoul and working as a section chair of ITI Section Korea. Due to the COVID-19, which began in January 2020, all academic events of this year's ITI have been conducted online. The topic I'm going to lecture today is strategy of implant treatment for elderly patients. The number of elderly patients is increasing very rapidly as the average life expectancy of human is getting longer. As you know, in 1993, Carl Misch presented the resorption stage of the upper and lower edentulous jawbone in 4 stages, which is still very useful in treatment planning. Stage 1 means minor ridge remodeling state, and almost all prosthodontic treatment options may be available. Stage 2 refers to the stage of severe ridge remodeling. This is the last stage where fixed type restorations are possible. Stage 3 has reached the basal bone ridge state. It can only be provided by a removable type prosthodontic treatment option like overdenture. Stage 4 has no alveolar bone due to resorption to the basal bone. Special measures are needed to secure stability even if a removable type protocol option such as an overdenture is provided. So, in developing the treatment plan, I hope to explain the various situations of the patient comprehensively into 3 categories. The first plan is to provide patients with fixed prosthesis under any adverse situations anatomically. Depending on the degree of alveolar bone resorption, a massive bone graft or enhancement surgery may be required. This is the result of the first option to complete the implant therapy with a natural tooth-like fixed restoration. The treatment option in the second category is so-called natural tooth-like hybrid fixed restoration method that places multiple implants on the severely absorbed and lowered jawbone and fills the vertical spaces with artificial gums. By the way, to produce such a large, long-span fixed prosthesis precisely and aesthetically high in completeness, a very excellent analog technology and digital workflow are required. The third treatment option is to use a removable overdenture. Although there is an inconvenience for the patient to take over, it easily fills the large deficit space and is aesthetically satisfactory. In order to effectively provide patients with the treatment options of the 3 categories we saw earlier, it's better to study in advance how to retain the prosthesis in the patient's mouth, check their strengths and weaknesses, and experience them clinically in advance. Indeed, historically, there are many ways in our prosthetic treatment options, from the Locators and the cheapest ball and anchor, in terms of technology and cost, to the bar joint and to the CAD/CAM bar structures and to the highest degree of techniques and high-cost fixed restorations. We would be able to determine which one is the most patient-oriented treatment option for the patient we treat. That's so-called the expert. It seems that many dentists often make wrong choices and recommendations in this respect. Frankly speaking, overdenture is not used by us dentists, but by the patient. All retainers for the removable type prosthesis should not be easy for dentists to use, but should be provided to be convenient for the patient and quickly familiar with. This is the most basic requirement and the most important clinical responsibility our dentist must take when the retainer selected. Until now, I have been emphasizing the meaning, necessity, and method of top-down treatment planning when educating my students at my university since 2004. As dentists, we should be able to create 4 to 5 treatment options for each patient and image each last treatment outcome to solve the chief complaint of every new patient. Before starting treatment, the habit of selecting one of the options through informed consent with the patient is necessary. Dentists should also be able to understand the aesthetic characteristics required by each patient to reproduce or improve the original aesthetic qualities of the patient. To give a simple example, there is a big difference between Westerners and Koreans' facial profile. Westerners are characterized by the fact that the facial profile has been concaved. The lips of Koreans are slightly protruding from the line connecting the nose tip and the anterior chin point, so they have convex facial profile overall. The next thing we need to study is to specifically design how many implants will be placed and what kind of prosthetic treatment will be provided on the edentulous jaws. The first option is to place 8 implants on the upper, 6 implants on the lower, and provide fixed restorations segmented by 3 to 4. The second option is to place 6 implants on the upper and 4 implants on the lower, and provide 1 unit fixed restoration each in the upper and lower. The third option is to wear a complete denture on the upper and provide a 1 unit fixed restoration to the lower 4 implants. But since these 1 unit fixed restorations require very high and precise technical skills in their manufacture, dentists and dental technicians must be fully trained in high-level technology and philosophy for smooth communication between the two sides. The first option is to plant 4 implants in the upper, install a 2-unit bar or 1-unit bar structure on it, install a 1-unit bar structure on the lower 2 implants, and then provide an overdenture to each of them. The fifth option is to provide a complete denture on the upper and placing 2 implants on the lower and connecting the single standing retainers. The sixth and the seventh options are when the edentulous jaws are heavily absorbed and lowered. With the sixth option, we can provide a complete denture on upper and on overdenture supported by bar structure for 2 implants on lower. Finally, the seventh option, the simplest method, is to provide complete denture on the upper and overdenture by connecting single standing retainers to 2 implants on lower. However, what is different from option 5 described earlier is that it's common to install a bar structure when the residual bone is so low in height, and if a single standing retainer is applied, the stability of the overdenture must be enhanced by selecting the one with a high vertical height. ITI Treatment Guidebook Series Number 9, published in 2016, describes implant treatments for the geriatric patients. Among them, Chapter 13.2, which I have authored, provides a detailed description of all the options described earlier on the implant treatment strategy for the elderly patient with edentulous jawbone. South Korea entered the aged society in 2020 when the lifespan of a human is expected to be 90 years. Therefore, dental care in Korea, where people aged 65 or older account for more than 14% of the total population, should naturally pay much attention and effort to these elderly patients. Old patients mostly own physical disabilities from small to large. Unfortunately, however, in a case of having to use the removable overdenture, the patients are forced to put themselves in their mouths and then take them out countless times a day. Many dentists have misselected the retaining devices based on their own convenience, making it difficult for patients who are users to use them properly. Retainer is a retaining device that keeps the overdenture from dislodging the oral cavity. Dentists should choose to provide disabled elderly patients with easy insertion and removal. The caregivers who take care of them should also be chosen to be able to handle this retainer easily. This is an iron rule. All of the treatment options described earlier, combined with the concept of immediate loading protocols, are grouped again as follows. The restoration-driven implant treatment approach is largely divided into 4 categories. The first is to place 6 to 8 implants in upper and lower jaws and carry out immediate loading with a fixed provisional restoration. The second is to provide complete denture on the upper edentulous jaw and 4 implants on the lower jaw, and to carry out immediate loading with a fixed provisional restoration. The third is to put a complete denture on the upper jaw or set up 4 implants and put on overdenture on them. And on the lower jaw, you set up 4 implants and load them with a fixed provisional restoration or an overdenture to carry out immediate loading. Fourth, complete dentures on the upper jaw, 2 implants on the lower jaw, and an overdenture on it to carry out immediate loading. As above, the implant treatment strategy for elderly people is based on providing immediate loading at all options to ensure that no meal is missed. As a typical clinical example of strategy 1, 8 implants were placed on the upper jaw and 6 implants were placed on the lower jaw, and immediate loading with a fixed provisional restoration. 3 months later, final restorations were installed. Similarly, as another clinical example of strategy 1, 8 implants were placed in the upper jaw and immediate loading with a fixed provisional restoration. In both of cases, the key to this category is that the patient has been able to take a meal since right after the operation. However, due to the development of digital dentistry, one more treatment strategy has been added to these 4 treatment strategies since 2006 and developed into a total of 5 treatment strategies. The 5th treatment strategy is to place 6 implants in upper jaw and 4 implants in lower and connect 1 unit fixed restorations to each. This is because the CAD/CAM process has enabled the production of highly precise prostheses. All of these are translated into the schematic diagram and explained as follows. If 6 implants were installed in upper jaw, fixed prosthesis is recommended. If the 4 implants are widely distributed in upper jaw, the roofless overdenture is recommended. If the 4 implants in upper jaw are narrowly distributed only in anterior maxillar, palatal coverage overdenture is recommended. If 2 implants are installed in upper jaw, overdenture with flexible type retainer is possible, but it's recommended to add 2 more implants to make 4. In the case of lower edentulous jaw, fixed restoration is recommended for more than 4 implants. 2 implants allow overdenture retained by bar joint structure or single standing retaining device. What should we do if we have only 2 implants in upper edentulous jaw for various reasons? In fact, for elderly disabled patients, there are many situations in which only 2 implants have to be placed in upper edentulous jaw, especially patients who have been using the upper and lower complete dentures for a long period often get flabby tissues in the anterior maxilla with the occlusal problem, also known as the combination syndrome, and the mucosa in the area continues to get impinging. It would be more desirable if 2 more implants could be added to the upper jaw if the patient's situation allows. I will show you the clinical practice of the last 7th option, which became an issue among the number of implants and the prosthetic options described earlier. The left side is the case of the lower jaw, and the right side is for the upper. Here, 2 implants that were placed in upper jaw used flexible type magnetic attachment retainers. The usual combination syndrome was painful, but with these 2 implants, all the discomfort and pain were disappeared. One of the greatest work of our ITI group is the consensus conference held every 4 to 5 years, where we judge representative clinical issues that we are curious about through the systematic review on clinical research papers accumulated for more than 5 years and publish them in the form of consensus document and provide treatment guidance for all the implantologists. The 2013 meeting also clarified the issue of whether immediate loading is possible for implant overdenture. The conclusion of our ITI group on loading protocol for implant overdenture is that it's possible to perform immediate loading if the insertion torque measured during implant surgery is 30 Newton centimeter or more. And since the result of immediate loading in maxilla showed more than 95% survival rate and 90% in mandible, it suggests that it's very important to measure the insertion torque during implant surgery and recognize the primary stability of implant. Although it was a short time, we shared the time to introduce the strategy of implant treatments for elderly patients and organize them around the treatment plans together. Peter Drucker said, "The most dangerous thing in an era of change is not preparing for it, nor accepting it and responding to it with yesterday's logic. We should not neglect starting to respond to the rapidly changing needs of patients and to accept a rapidly changing treatment trend and modality." Thank you for listening.